start कर this? Good afternoon, everybody. Today's CCR is being presented by Department of Radiation Oncology at IRCH AIMS, and we have decided to present a very interesting case. It's a small cell neuroendocrine carcinoma of base of tongue, which is a very rare disease to encounter, and till now only 30 cases have been reported in the literature. And surprisingly, these tumors which arise from the extrapulmonary sites, they do well when we compare the outcome with the pulmonary small cell carcinomas, which are relatively commoner. And the treatment, because they are so infrequent, so there are no defined guidelines as yet as to what should be the optimum treatment, but whatever the treatment protocols which have been followed in various series in the literature have been mainly extrapolated from the pulmonary small cell carcinoma experience. So now I hand over to our residents Narayan and Minal, who will be presenting the case, and followed by Dr. Ritesh, Assistant Professor in the department. Thank you.
Thank you, ma'am. Respected faculty, seniors and colleagues. Now I'll present the case. 61-year-old male patient, resident of Haryana, electrician by occupation, of lower middle class family, presented to Head and Neck Clinic IRCH AIMS in October 2013 with chief complaints of difficulty in swallowing for 1 month and awareness of swelling in the right upper neck for 1 month. The difficulty in swallowing was insidious in onset, progressive in nature, more for solids than liquids, and was associated with pain. Similarly, the awareness of swelling in the right upper neck for 1 month was also insidious in onset, progressive in nature, and was painless. There was no associated history of breathlessness, abdominal distension, yellowish discoloration of the eyes, bone pain, headache, or seizures. There was also no history of weight loss or loss of appetite. On past history, patient did not have any significant comorbidities. There was no history of diabetes mellitus, hypertension, coronary artery disease, asthma, tuberculosis, or hypothyroidism. There was no history of any major hospitalization or any surgery or chronic drug use. On personal history, patient was a chronic bidi smoker of 20 pack years. He was occasional tobacco chewer and he was non-alcoholic. There was no family history of malignancy in the family of the patient. On general physical examination, the general condition of the patient was Eastern Cooperative Oncology Group performance status of 1. Patient was well built and well nourished. Patient was alert, conscious and cooperative. He was oriented to time, place and person. There was no pallor, icterus, edema, cyanosis, clogging. On systemic general examination, no abnormality was detected. On local examination, on inspection, mouth opening was adequate. There was no visible lesions in the oral cavity. Teeth was tobacco stained. The oral part of the tongue, buccal mucosa and floor of mouth did not reveal any visible lesions. On palpation, there was indurated lesion of 4 into 3 cm at the right side of base of tongue. There was also 2 into 2 cm right level 2 or the upper jugular lymph node, and right level 3 2 into 1 cm or the mid jugular lymph node, and left level 2 1 into 1 cm or the left upper jugular lymph node was palpable, which was firm in consistency, mobile and non-tender. The image shows the pictorial representation of the growth at the base of tongue, which was 4 into 3 cm in dimensions, mainly in the right side of the base of tongue. On indirect laryngoscopy, there was growth in the base of tongue, which was crossing midline, involving bilateral vallicula and epiglottis. Following the history and clinical examination, baseline investigations were carried out. The complete blood counts, liver function tests and kidney function tests were normal. Chest X-ray was done, which did not reveal any abnormality. The management was further continued with CECT of the face and neck region. On CCT of 4 into 2.6 into 2.4 centimeter ill-defined mass involving the base of the tongue, extending inferiorly to involve the vallicula and epiglottis was observed. There was infiltration of adjacent tonsillar fossa and lateral pharyngeal wall. There were multiple enlarged, discrete and conglomerate lymph nodes on bilateral level 2, right level 3. Largest was measuring 2.8 into 1.6 centimeter on the right level 2. You can see the CCT image here. The enhancing mass in the right side of base of tongue is seen, represented by the vertical arrow, and there is also well circumscribed enhancing mass in the right, representing right level 2 enlarged lymph node, represented by the horizontal arrow, and there is also small 1 into 1 centimeter lymph node in the left.
CCR final आज का डेट नीचे कर लीजिए और नीचे हाँ
ये ना
नहीं वो नहीं वो विथ डेट दिस फर्स्ट दिस
Following the CCT of face and neck, biopsy from the lesion at the base of tongue was performed. Now I would like to request my pathologic colleague to explain the histopathological part.
Good afternoon everyone. We received biopsy from the lesion. This photomicrograph shows a tumor located predominantly in the subepithelial region. The overlying squamous epithelium is unremarkable without any dysplastic changes, and the tumor cells are arranged in nests which are separated by thin vascular septae, and the individual tumor cells are small and have scant cytoplasm with brisk mitotic activity, and apoptotic bodies were also prominent. So morphologically, it was suggestive of a small cell carcinoma. This was further confirmed by immunopositivity for chromogranin, which is a neuroendocrine marker, and a very high MIB1 labeling index of about more than 90%, which confirmed the diagnosis of small cell carcinoma. And since most of the oropharyngeal cancers are HPV related, we perform P16, which is a surrogate marker, immunohistochemical marker for HPV infection. And interestingly, this tumor also turned out to be P16 positive. So the final diagnosis was small cell neuroendocrine carcinoma of base of tongue, possibly HPV related. Thank you.
As said by my pathology colleague, the tumor was consisting of multiple foci of necrosis and high MIB labeling index. So it was suggestive of poorly differentiated high-grade neuroendocrine carcinoma, and it was after the immunohistochemistry diagnosed as small cell neuroendocrine carcinoma of base of tongue. So we continued the management with further investigations to rule out any systemic metastasis or presence of the similar lesions in other parts of the body. Bronchoscopy was done. It revealed the growth at the base of tongue and bilateral vallecula, but larynx, trachea, carina and bilateral bronchus were normal. CCT of the head, chest, abdomen and pelvis was done, which also did not reveal any evidence of systemic metastasis. Then a final diagnosis of small cell neuroendocrine carcinoma of base of tongue was made. It was clinically T3, N2C, M0, stage 4A according to AJCC 7th edition 2010 classification. It was positive for the surrogate marker of human papilloma virus, and it was limited stage according to the Veterans Administration Lung Cancer Study Group classification Generally, the Veteran Administration Lung Cancer Study Group has devised the staging system for small cell cancer of the pulmonary region as limited and extensive disease. Limited stage disease are those which come under the one tolerable radiation portal, and similar staging system is followed in extrapulmonary neuroendocrine tumors, small cell tumors, and there are also the TNM staging in the literature for this kind of tumors which are extrapulmonary. So we have given the both kind of staging. But the neuroendocrine tumors of the gastrointestinal tract, mainly gastroenteropancreatic neuroendocrine tumors, are staged separately, and different AGCC system of classification is available for gastroenteropancreatic neuroendocrine tumors. So, following the diagnosis, the treatment plan was made in the head and neck clinic, comprising of the radiation, medical and surgical oncologist. So the treatment was planned with neoadjuvant chemotherapy with cisplatin 80 mg per meter square and etoposide 100 mg per meter square day 1 to day 3 every 3 weeks for 2 cycles, followed by radical chemoradiotherapy. Post 2 cycles of the neoadjuvant chemotherapy, there was partial response with 50% reduction in the size of the primary and the nodes on clinical examination. So the treatment was further continued with radical chemoradiotherapy to a dose of 70 gray in 35 fraction over 7 weeks with concurrent weekly cisplatin at the dose of 40 mg per meter square. Post 5 weeks of chemoradiotherapy, patient developed grade 2 skin reactions and grade 3 mucositis, which was managed conservatively. Treatment was completed without any grade 3 or grade 4 toxicity and treatment interruption. So post treatment, after 1 month, there was complete clinical and radiological response on first follow-up. Patient was kept on 3 monthly regular follow-up. On regular follow-up, there was no evidence of disease, but after 1.5 years of the treatment completion, patient developed acute onset weakness of the right side of the body with altered sensorium. So CECT air was done, which revealed multiple lesions in the brain with perilesional edema, which was suggestive of brain metastasis. So patient was managed conservatively with medical decompression with steroids and mannitol, and was planned for palliative radiotherapy to a dose of 20 gray in 5 fractions over 1 week to the brain. But the patient expired before starting the palliative radiotherapy. So now I would like to request Dr. Minal for the discussion and review of the literature part.
Coming to the discussion part, this small cell lung cancer is a small cell carcinoma of the base of tongue is a rare histological diagnosis, and we'll discuss the treatment options, the prognosis of this disease, and the role of prophylactic cranial irradiation in the coming slides. Carcinoma of the base of tongue occurrence is generally in the 5th to 7th decade of the life. There is a male predilection for this disease. It is associated with tobacco and alcohol consumption, and nowadays HPV related cases are also increasing. Most of the cancers of the base of the tongue are squamous cell type in histology. Other less frequent histological types of oropharyngeal cancers are anaplastic carcinomas, adenocarcinomas, adenoid cystic carcinomas, lymphomas, melanomas, and plasmacytomas. Neuroendocrine tumors thought to arise primarily from the neuroendocrine cells of the lungs and the GI tract. Rare in the head and neck, with larynx being relatively commoner site. 1.5% of all laryngeal cancers are small cell carcinomas, and only less than 30 cases have been reported till now in literature in the base of tongue region. So it poses a diagnostic challenge. Small cell carcinomas are rare in oropharynx. There are only few case reports and small series available in the literature. There are no guidelines for proper pathological grading of this site. The criteria of grading of neuroendocrine carcinomas in pulmonary and GI tracts vary. And HPV positivity, it has a prognostic significance in squamous cell carcinoma. There is a paucity of literature in small cell carcinomas for HPV positivity. It also imposes a therapeutic challenge because there are no guidelines for treatment of small cell carcinoma in head and neck due to their rarity. Treatment decision is to be taken after looking at the behavior of these kind of tumors, like small cell carcinoma of the lungs and the site of the disease, that is head and neck. Proper pathological grading must, since low grade and well differentiated neuroendocrine tumors are treated differently. These are aggressive tumors, so optimal treatment strategy to be formulated before deciding the treatment plan. Extrapulmonary small cell carcinoma, the median survival is only 14 months, irrespective of the site of origin. Initial stage at the time of diagnosis and the location of disease are independent factors for survival. Now coming to the review of literature of small cell carcinomas of the oropharyngeal region, there are only a few case series and case reports. In this one study by Khurana et al., this case report of one patient aged 56 years of the carcinoma of the small cell carcinoma of the base of tongue. The treatment was 3 cycles of neoadjuvant chemotherapy followed by external beam radiation to a dose of 66 days in 33 fractions over 6.5 weeks. The patient developed recurrence in the 5th month. In another study by Bishop and Vesta, they included 9 patients of the median age of 61 years. Out of them, 8 were male and 1 was female. The primary site was tonsil in 6 patients, base of tongue in 2 patients, and soft palate in 1 patient. 5 patients were HPV positive and 4 were HPV negative. The treatment strategy followed was surgery plus chemotherapy plus radiation in 5 patients, surgery alone in 1 patient, and chemotherapy alone in 2 patients, and chemoradiation in 1 patient. Mean survival in this study was 9 months, and 7 patients out of 9 died of distant metastasis. And this another study of 2 patients by Bates et al., 59 year of patients comprising of age of 59 years and 64 years respectively. 1 was male and 1 was female. Both primary site was tonsil. HPV status of both the patient was positive. For the first patient, 6 cycles of neoadjuvant chemotherapy was given, followed by radiation to the primary and neck to a dose of 65 gray in 30 fractions over 6 weeks. For the second patient, excision of the primary and bilateral neck dissection was done, followed by adjuvant radiotherapy, 63 gray in 30 fractions over 6 weeks was given. In the first patient, distant metastasis developed in around 12 months and disease-specific survival was 15 months. For the second patient, distant mets was developed in around 25 months, that was liver mets, and disease-specific survival was 26 months. In this another study of 4 patients by Saha et al. From our institute, the patients included were median age of 55 to 62 years, 2 were males and 2 were females. 2 patients had a primary of base of tongue, 1 from vallecula and 1 from esophagus. HPV status was unknown. These patients were treated with neoadjuvant chemotherapy with cisplatin and etoposide combination regimen. Total 2 to 6 cycles were given, followed by chemoradiation in 2 patients, radiotherapy in 1 patient, and palliative radiotherapy in 1 patient in view of distant mets. In follow-up, 3 patients were alive with no evidence of disease at the last follow-up. The median follow-up was around 22 months. 1 patient died of disease at 8 months. In this another study by Kraft et al., total 8 patients were included, 59-year median age, 6 were males and 2 were females. Carcinoma site was oropharynx. 7 out of 8 were HPV positive. Treatment was surgery plus chemotherapy and radiation was given in 2 patients, chemoradiation in 1 patient, radiation alone in 2 patients, and chemotherapy alone was given in 1 patient. Out of these 8, 2 were lost to follow-up, and out of the 6 patients, recurrence was seen in 5 patients, with 3 patients developed distant metastasis. And this is another study by Latif et al. Of 1 patient, a 56-year-old male of carcinoma base of tongue. Chemoradiation was given and radiotherapy to a dose of 74 gray was given, and 2 cycles of chemotherapy was given in this patient. Post-treatment, the patient had a complete response, then the patient lost to follow-up. Now coming to the role of prophylactic cranial irradiation in these patients. Limited stage small cell carcinoma of the lungs are treated with systemic therapy plus concurrent radiation. Prophylactic cranial irradiation is an integral part of the treatment. This has shown survival benefit in limited stage small cell lung cancer. However, the role of prophylactic cranial irradiation is not clear in extrapulmonary small cell carcinoma. In this retrospective study published in Cancer 2010, should extrapulmonary small cell cancer be managed like small cell lung cancer? They include a total of 120 extrapulmonary small cell carcinomas. So they found out that the lifetime risk of brain metastasis is 13% in extrapulmonary small cell carcinomas as compared to small cell carcinomas which has a lifetime risk of around 40%. So this is significantly less. And first site of failure of, in the brain is around in 4% of the patient. So they concluded the potential benefit of PCI in extrapulmonary small cell carcinomas is less as compared to small cell carcinomas. Now coming to the site-wise survival of extrapulmonary and extrapulmonary small cell carcinomas. For lung limited stage disease, 5-year survival is around 20 to 25%. For lung extensive stage disease, 2-year survival is around 5%. For esophagus small cell carcinoma, 5-year survival is 5%. For bladder small cell carcinoma, 5-year survival is 20 to 25%. For early stage carcinoma of the cervix, 5-year survival is 25 to 30%, and advanced small cell carcinoma of the cervix, 5-year survival is only around 5 to 10%. Now I'd like to request my medical oncology colleague to discuss the chemotherapy part.
Thank you. So I'll just quickly go over the role of systemic therapy in neuroendocrine carcinoma. As all this has already been discussed, so it's an uncommon histology in head and neck region, and treatment strategy tends to be extrapolated from NEC or more common sites, that is lung or GI tract. So the pathological grading of neuroendocrine carcinomas tends to be very important because the disease biology and therapy will both depend on the pathological grading. So generally we divide them into lower intermediate grade, which are the so-called carcinoid tumors, and high grade or poorly differentiated tumors, as is in the current case based on the number of mitosis per HPF and the Chi67 index. So this is just an approach for therapy which just to show how it depends on the grading. So patients, this is for GI tract neuroendocrine tumors, and patients who are resectable at diagnosis tend to go straight away for surgery. Regarding the other patients who are metastatic and unresectable, it depends on the histology. Patients with poorly differentiated tumors, as is our case, tend to be treated with chemotherapy, while patients with well differentiated tumors tend to be offered other therapies. So the disease tends to be very aggressive and progression is very rapid. It has been seen that patients who have a deterioration in PS have a significantly poorer prognosis, and ideally therapy should be initiated within 1 week of diagnosis. The general approach again has been discussed. Localized resectable disease may be offered upfront surgery with adjuvant chemotherapy and or radiotherapy or definitive chemoradiation. Unresectable localized disease which is amenable to definitive chemoradiation should receive definitive chemoradiation, and we use palliative chemotherapy for metastatic disease. So the standard of care chemotherapy for several decades is cisplatin etoposide. This is originally extrapolated from studies of small cell carcinoma of lung. We will see a response in half to 1/3 of patients, and around 1/3 patients will have stable disease with progression in the rest. The response is generally rapid. You will see it within 1 or 2 cycles, although the duration of response is generally short-lived. It has been seen that patients who have got higher grade with MIB index of more than 55% tend to have a better response, but these opposite to that, they have a worse outcome. So higher the grade, better the response, but worse the outcome. Other alternative regimens for patients who are not candidates for cisplatin etoposide can be carboplatin etoposide or capecitabine and temozolomide. And now back to my colleagues for delivering the concluding statements.
Thank you. The case has been already discussed in detail, and all the therapeutic options and management issues have been discussed. So to conclude, the small cell neuroendocrine carcinoma of base of tongue are rare tumors, and they are aggressive, irrespective of the HPV status of the tumor. Though we know that with HPV positivity, the prognosis is good in other oropharyngeal cancers. It possesses some diagnostic challenges, and optimal treatment strategy is still not available. It is extrapolated from the small cell carcinomas of lung. It requires multidisciplinary approach, and it carries poor prognosis. Thank you. And now the case is open for discussion and comments.
Do you look for any other sexually transmitted infection in these patients, or is it too late?
HPV associated cancers are especially seen in oropharyngeal cancers, and it modulates the prognosis. So, they are mainly seen in young sexually active patients, and their prognosis are better as compared to the other counterparts who are non-HPV positive. And regarding other sexually transmitted disease, they don't have any impact on as such prognosis in head and neck cancers.
So do we screen them? That's what I mean.
Oh no, routinely we don't screen them.
going on?
Please use that recommendation.
There's no such thing. So what is the age of your patient?
He's 61-year-old.
So if the person was 25-year-old, would you be working it?
As per our Indian data, especially from the institute, the HPV positivity in oropharyngeal cancers is around 25%. We have seen from our data. So, and our data is different from the Western data where they have high prevalence of HPV positivity in oropharyngeal cancer, ranging to 60 to
So
70%.
your patient was positive. That's why I was interested. As a dermatologist, I wanted to know whether you mean that for other sexually transmitted diseases, patient vidiana to be done or retroviral to be done. If not, there is a status, then the have to take it out.
As a policy decision, we don't routinely screen them.
Okay.
It can be done. We can proceed to the next case. We'd like to acknowledge the supporting departments, Department of Pathology, Radiology, and Medical Oncology for their support.
From the Department of Surgical Oncology, we are presenting an uncommon tumor. This is bone to gigantic size. And Dr. Ray and his team have fought like a war and controlled the disease. Dr. Ray? Dr. Parvesh will present the case and Dr. Ray will discuss it.
Thank you, sir. Going to the case, our patient was a 30-year-old housewife, a resident of Bhagalpur, Bihar. She had no medical comorbidities. She was from a low socioeconomic status. She was premenopausal, no menstrual irregularities. She gives history of abortion, no living issues at that time. She gives history of a lump abdomen since 11 months, however not associated with any pain or bowel bladder disturbances. For these complaints, she was evaluated outside, underwent left ovarian cystectomy. Unfortunately, we don't have any intraoperative surgical details, histopathological details, nor any serum markers at that time. Following this, she was referred to another center where she received 3 cycles of chemotherapy. She was asymptomatic for about 3 months. Following this, she developed recurrence of the lump, progressively and rapidly increasing in size. She was referred to various other centers where she was refused treatment just because of the enormous size of the mass. She also gives history of having attempted suicide a couple of times due to frustration. When she landed up with us, on examination she was an anxious but cooperative patient, good performance status. She had no pallor, icterus, edema or lymphadenopathy. Her vitals were within normal limits. Bilateral breast and axilla examination was normal. On abdominal examination, the abdomen was distended with dilated veins. She had a midline scar of previous surgery. There was a 25 by 30 centimeter firm to hard mass involving all the quadrants of the abdomen with restricted mobility. There was no free fluid. On pervaginal examination, the mucosa appeared normal, but there was extensive compression along the anterior wall. Rectal examination was normal. Her routine blood investigations were normal. We got the serum markers done. Beta-HCG, AFP, CA, CM25 all were within normal limits. Chest X-ray, bilateral mammogram was also normal. We did a cystoscopic examination on her which showed a normal bladder mucosa. However, there was compression along the anterior wall of the posterior wall of the bladder. Sigmoidoscopic examination showed normal mucosa. We got a contrast enhanced CT scan done. I'd like to request Dr. Anuradha from the Radiology department to shed some light on the radiological findings.
Good afternoon. These are the CECT sagittal. This is the CECT sagittal image of this patient, which shows the presence of a large mass of heterogeneous attenuation in the abdominopelvic location. Cranially, the mass extended till the undersurface of the liver. This is the liver, and this is the cranial extent of the mass. And caudally, it extended till the pelvis, and bulk of the mass was epicentered in the left heavy pelvis. Additionally, the mass contained was of heterogeneous attenuation and showed presence of calcific foci, fat attenuation, and cystic component within. This is the loop of ascending colon. The lesion was completely engulfing the ascending colon. However, there were no features of bowel obstruction at the time of scan. Additionally, there was presence of mild ascites, but there was no significant retroperitoneal lymphadenopathy. And this is the bladder. There was loss of fat planes with the bladder also. Similar lesions are present in the liver and bilateral lungs also. So going by the imaging findings for the presence of calcification, cystic component and fat attenuation within the lesion, imaging findings are suggestive of a teratoma.
Thank you, Dr. Anuradha. We again sought the help of our radiology colleagues to get a guided biopsy from the mass done. Biopsy showed a fibrocollagenous stroma with glands, columnar epithelium, goblet cells, mucinous glands and cartilage, all suggestive of germ cell tumor, probably teratoma. So putting all the pieces together, we have a young female with biopsy-proven germ cell tumor, increasing in size post-chemotherapy, however with normal markers. All these were suggesting of probably a case of growing teratoma syndrome. So we decided to take her up for surgery. I'd like to request Dr. Ngire to tell us about the surgical details.
Respected senior teachers, my colleague and friends, you see from this OT table, the patients, the huge lump occupied almost all the quadrants of the abdomen, and this scar is due to the previous surgery and done in the Bihar. And we just made a midline incision that is extended from the GP sternum to the symphysis pubis. That is a big lump. But I could not get the access with that lump, so I just we made another incision in the horizontal incision in the mid abdomen, so to get the access of the lump. Suddenly, when we just made this incision, all of a sudden we see just this thing, just hippopotamus came out like that. So why just I made this thing hippopotamus? When hippopotamus was inside, we could predict very the smaller part. When it came out, we can see how big it was. And why I compare, because this mass with the hippopotamus, there are so many similarities with the hippopotamus with this teratoma. You know, teratoma is so-called benign tumor, and the hippopotamus, you know, by food habit, hippopotamus is herbivorous and eats only the plants. But by behavior wise, it is very aggressive, aberrant, and very unpredictable, like a hippopotamus. And you know, this is a so big mass in teratoma, still it is growing so faster and invades the multiple organs. Like the hippopotamus, you know that the average weight is around 1,300 to 1,500 kg, but it runs very fast, 30 km per hour. You know, like the same similarity with the teratoma. So I like to put this picture to compare with this hippopotamus. So now what happens particularly, we know we just mobilize all the mass like that, and we see the colon, left-sided colon is invaded with that mass, and we mobilize from the surrounding area, from both the walls. And sometimes I am thinking like that this mass is so big like that, I thinking, and suppose we could not resect that mass, how could we close the abdomen totally? And ultimately we resect this, both the ends of the colon which was involved, appears to be involved. But I see the base is very fixed to the retroperitoneum. So just so many people must have seen this butter ball in the Mahabalipuram, Chennai. You know, I see this thing, butter ball, this is a rock is there, the sliding rock, and so big rock that is attached slightly based on the base. And I don't know how it is attached to the base. Here the mass is attached to the base, and you know this kind of mass like to infiltrate the surrounding structure, the vital organs like duodenum, retroperitoneum, like the major vessels like the IVC and outer. So that time I was afraid of, like we mobilized this mass, but I didn't know about this thing, what the IVC, how the IVC was there and how the outer was there, because I couldn't palpate that outer at all. So if you see this, another mass was peeping like that here in the base of the bottom of the large mass. It was peeping like that. I didn't see this thing. What is that? Like the tip of the iceberg. So ultimately, I see what I just when I open this thing, I see this thing mass is that this mass is just engulfing that. This is the bladder. This is the bladder. I think that time I was remembering that Sholay ka dialogue. Ye haath na Thakur phansi ka phanda hai. So like I was thinking like those, so engulfing the total bladder. So I just cut open this bladder, I see it was indented to the bladder. The mucosa was appearing normal, but this part of serosa, totally you could appreciate this serosa is invaded by particularly this part. So I had to remove the part of the bladder along with the second mass. Another one mass was there, that is in the epigastric region, and that mass was totally displaced the pancreas and the spleen, the duodenum and this stomach and the liver. It was firmly stuck with the diaphragm, but we just gradually resected out all from the surrounding structure. So ultimately we achieved RG2 dissection by removing all the masses, and we had to do the subtotal cystectomy along with that mass, and definitely the left-sided colectomy done. But I just palpated because sometimes the pelvic and parotid nodes are involved, but we see this, there is no pelvic parotid nodes are there, and luckily the root of mesentery was not involved. So ultimately you see this huge mass was there, just I taken out this big mass, and this can you see that this bladder part I removed here also. This bladder is removed along with the mass. And this thing total ultimately in epigastric mass, total 3 masses are there like this. One is the main mass, another the involvement of the bladder, another is the epigastric mass. So that total the dissected specimen is like this. And this is the hysterectomy specimen, already one-sided salpingo-oophorectomy done in the Bihar, another one this is the hysterectomy specimen, thereby we remove. And ultimately the reconstruction done, we know augmented cystoplasty with the ileum, and definitely the continuity of the guard maintained by the colorectal anastomosis as usual. So I see this thing, the 30 to 40 centimeter ileum, I just took this thing, and we made a pouch, and ultimately we anastomosed with the rest of the bladder. We see the both the ureter orifice was normal, the trigon area was normal, luckily. So this is around the 300 to 350 ml of the volume was there in the new bladder. So ultimately we did the new bladder by the ileocystoplasty. And ultimately the post-op period, you can say always the post-op care, the post-op period was relatively uneventful because some urinary leakage was there for the first 7 days. But ultimately the second day patient was shifted to the ward normally, and within 7 days the leak was over automatically. And with the weight of the resected patient was 17.2 kg, and the weight reduced to that patient from 60.5 kg to 42 kg. And this is this patient. And ultimately the recent follow-up only just 1 week back the patient came, already the surgery done 1.5 years back. The patient came like this, we did the routine investigation like blood count, chest x-ray, USG, abdomen and pelvis, and all the markers. As you know, these kind of patients can develop the secondary malignancy like leukemia. So always you do the road date count and see the markers, but all are within normal even, and she is doing absolutely fine. So I just like this, close this chapter with this nice quotation like that, how the destiny is created. You know, our destiny is created not by the shoes you wear, but definitely the steps we take. That is definitely that is there. And now I just like to invite my anesthetic colleagues, Dr. Binod. You know, always sometimes I feel without anesthesia the surgeon life is meaningless. So Dr. Binod, please.
Thank you, Dr. Ray. Good afternoon, everyone. The anesthetic management of this growing teratoma is quite challenging. As Dr. Ray has described the huge mass of around 17 kg, there are some concerns like the patient of having risk of aspiration pneumonia. Then due to large mass, there will be diaphragmatic splinting that may lead to poor respiratory compliance, and in perioperative period as well as in post-op also there will be basal atelectasis which will lead to desaturation. So respiratory parameters will be a challenge. Then this such a huge mass may definitely compress the IVC during supine position, so there may be hemodynamic instability. In addition, such a long duration surgery, this surgery lasts for 9 hours, so there will be blood loss, massive blood loss during the surgery, so there will be hemodynamic instability, and due to that, due to this, to maintain the hemodynamics we have to give fluids, crystalloid and colloid in addition to the blood loss, so there will be major fluid shifts, and prolonged surgery may lead to hypothermia if it is if there is hypotension as well as there hypothermia. So this patient has a past history of PONV, and her airway examination as well as other investigations were normal except for deranged PFT, pulmonary function test, which shows decreased compliance. So we prepared the patient by giving Rentec 150 mg night before surgery and 2 hours before shifting to the operation theatre with sips of water. We optimized her respiratory parameter by doing active incentive spirometry every 2 hourly and steam inhalation before surgery. So our anesthesia plan was epidural pre-op before induction, and after that general anesthesia. Epidural was given at L2 L3 18 gauge. To avoid the risk of aspiration, we did rapid sequence induction with low tidal volume. We pre-oxygenated the patient with 100% oxygen. Fentanyl 100 mics were given. Then thiopentone 300 milligram and scopolamine 100 milligram were given. The airways were normal, so intubation we didn't face any difficulty, and we intubated the patient with the orotracheal cuff tube 7.5 millimeter internal diameter, and we maintained the anesthesia with oxygen, air, and sevoflurane. And after that, we give vecuronium for muscle relaxation. After induction of anesthesia, we put central venous catheter in right IJV for CP monitoring, and right radial artery cannulation was done for invasive BP monitoring. The anesthesia was multimodal. We give epidural as well as we give paracetamol 1 gram 6 hourly, and we monitored patients' ECG, heart rate, invasive blood pressure, CVP, monitored anesthesia air, and urine output and core temperature. This is already told. The duration of surgery was 9 hours. The estimated blood loss during the surgery was 2.5 liters. Urine output was 450 ml. Crystalloids 6 liters were given. Colloids were 1 liter. We infused blood and blood products like RBC 4 units, FFP 4 units, and pegged RB plasma rich proteins 3 units. To maintain hemodynamic stability, inotropic support was given. Since the patient was on high dose inotrope noradrenaline, she was not extubated and not reversed. She was also having low temperature during the surgery, so we have not reversed and shifted her to ICU for overnight mechanical ventilation. She was extubated next morning, and it was uneventful, and next day she was shifted to ward. Thank you.
Thank you, sir. I'd like to request Dr. Madhu from Pathology Department to tell us about histopathological details.
So as shown already, the mass was huge, about 30 centimeters in size, and the surface was lobulated. Most of the places were surrounded by a fibrous pseudocapsule, but it was adherent to the colon. And cut section not shown here was solid cystic with presence of multiple mucus-filled cysts. Focal calcified areas were also seen. And microscopic examination showed derivatives of all 3 germ layers, like the skin and the skin appendageal structures and the mature glial tissue representing the ectodermal derivatives, mature fibroadipose tissue, lobules of cartilage and bone from the mesoderm, and the respiratory type of epithelium, and mucous glands representing endodermal derivatives. So the tumor was adherent to the serosal aspect of the colon and bladder. However, there was no infiltration of the muscular coat or the mucosa. There was no immature neuroepithelium, ruling out an immature teratoma, and no other germ cell component was seen, ruling out a mixed germ cell tumor. So the final diagnosis was mature teratoma. Thank you.
Thank you. Just I am going to the review of literature. You see, first we can say this one article that is 2009 published in Indian Journal of Urology. If you see the review of literature, there is very scanty papers are there as a whole. You see the literature, and hardly I found in one Japanese literature there total 55 cases reported. So you say this is rare condition definitely, and seen in the among the patient of non-seminotomous germ cell tumor occurs in the younger age group, particularly in the first and second decade. And earliest youngest age group reported that is 5 years. Initially in 1977, that Dai Sahiya et al. They described the ovarian germ cell tumor, but that was not properly described. But the term GTS, the growing teratoma syndrome, that is coined by Logothetis et al. In 1982. So the prevalence rate is also very low, that is 1.9 to 7.6%. But the growing teratoma syndrome related to testis and ovarian carcinoma have grown in number nowadays. So the most common site is retroperitoneum, definitely like in our case also that invaded the retroperitoneum, but it also can be found in the lung, mediastinum, it can present in the supraclavicular node, inguinal nodes, like in the forearm, mesentery, liver, almost on every part in the body like that. So normalize the diagnosis criteria, the normalization of the previously elevated marker, if somebody having the germ cell tumor and giving the chemotherapy, and ultimately the normalization of the elevated markers, increasing the tumor size during or after chemotherapy. All that is very important criteria, and ultimately the presence of mature teratomas component only in the resected specimen. That is the most final diagnosis for the growing teratoma syndrome. So the etiology, if you say the etiology, that is more or less unclear. That is to tell the truth, there is no clear-cut etiology is there, but there are so many hypotheses are there how the growing teratoma syndrome occurs. Like first hypothesis is that the chemotherapy destroys the only immature malignant cells. So the mature cell, they keeps on growing and they form the growing teratoma syndrome. And second hypothesis is that the chemotherapy can alter the cell kinetics towards the transformation from a totipotent malignant germ cell to a benign cell, to means a mature teratoma. So that is also the second hypothesis that is also published in 1975 and 1981. And third one is the inherited spontaneous differentiation of malignant cells into the benign tissues. That is Hong et al. They published in Cancer in 1975. So, but these are the ultimately diagnosis, how we diagnose the high clinical suspicion, particularly this case, we see the high clinical suspicion, patient underwent 3 cycles of chemotherapy. Despite of that, the tumor was growing. So, another the history of NSGCT, non-seminoma germ cell tumor, increasing in size in the metastatic lesion on the serial imaging, like you see the serial imaging, the increasing in the size during or after systemic chemotherapy, and obviously the serum markers will be normalized. Sometimes the serum markers may be elevated, then we have to exclude the other causes of the elevation of the serum markers, like in the malignant, other non-malignant etiology, like elevated AFP in the liver dysfunction, we all know, elevated beta HCG from the marijuana use, etc. And histopath report ultimately the presence of mature teratoma and absence of any malignant germ cells on the final surgical histopathological report that prove that that is a growing teratoma syndrome. So the management part, if you see, the surgery is the gold standard. There is no question of there, other things, no doubt is there about that. The completeness of the surgery is the main, that the curative treatment. And there is 90% 5-year survival is there, even the 10% survival is up to 70%. And you see, if you do the complete surgical resection, the recurrence rate is only 0 to 4%. There may not be recurrence also there, that 0% is also there. But if suppose incomplete resection is there, you leave behind the tumor, because I already mentioned when I was thinking about that great vessel, I put all my fingers there and just dissected just above the finger like that, whether that the main vessel should not be ruptured like that. But I feel if the dissection is complete, that there is the chance of recurrence is very less, but incomplete dissection it is 50 to 83%. And so complete surgical resection of the growing teratoma syndrome is open curative, that is very important sentence. And few roles of medical therapy, definitely the one literature suggests interferon therapy has got some role. And in inoperable disease, multiple organ involvement was there, great vessel involvement was there, and fistula was there. And they put that interferon therapy for 8 years, and that was not growing, that teratoma. So another one is the use of bevacizumab also, 10 milligram per kg biweekly for the 6 months. They have given that they arrest the growth like that. So few literatures available about that. And then definitely there is no role of radiotherapy and chemotherapy in the growing teratoma syndrome. So now the few points in the GTS in India, like growing teratoma syndrome in India, there is 2 case reports are there from the India, one from the Institute of RDR Madras in 1995, the Ruby et al. He published, and the patient was totally disease free at 24 months after resections, and another report from the Tata Memorial Hospital, Mumbai, and the patient was disease free 6 months after R0 resection. So before the publications like that, and recent was in ours also, we published also this paper, that is the one, the Journal of Community and Supportive Oncology, USA based PubMed Index journal, and that is published in May 2016. So we published by the headline multivisceral resection from growing teratoma syndrome, overcoming pessimism. So we reported because it is the largest one in the growing teratoma syndrome, weighing 17.2 kg after resection, and we wanted to emphasize that the complete surgical resection should be the aim of the surgery, which may include the multivisceral resection. So, so I could conclude with the summary, like germ cell tumor, the 2 most important, 2 challenging aspects for the surgeon. One is the growing teratoma syndrome, definitely, when sometimes growing teratoma syndrome involving the multiple organs, even the major vessels. And another is that the transformation of the teratoma into the varieties of malignancies, like adenocarcinoma, sarcoma, even neuroendocrine tumor, even leukemia. So many the malignancies can be there from the teratoma. So the early detection and early surgery is the mainstay of therapy. There is no doubt about that. As early as possible we detect that we can cure the disease, and all because all are chemo and radio resistance. And so we know the overall 5-year survival of teratoma, if you resect properly and that R0 resection is achieved, that is more than 90%. While in malignant transformation, it suddenly drops down to 50 to 60% in 5-year survival. So as a take-home message, I can say, like the patient with giant growing teratoma, that should not be declared unresectable at all until the proper surgical exploration in an expert center has failed to achieve the complete resection. So I feel the complete resection is the curative for the patients. Thank you very much. Any question or comments from the audience, please?
So we had given epidural perioperative, and we continued it. We give epidural morphine 3 milligram twice a day, and in addition we also give paracetamol 1 gram 6 hourly. So patients' pain scores were around NRS of 3 to 5 most of the time. We keep the catheter for 5 days post-operative.
5 days.
Yes.
Because as you said, in this kind of surgical removal, now studies have shown that either the good pain control is very important and complete recovery of patient. And you added anti-inflammatory because tumor has a lot of anti-inflammation. And there is a role for roficoxib, levothyroxine in this. I don't know what you have to say about that. Cutting levothyroxine for the next 6 weeks. Cut down the inflammation. Any restriction on that?
Sir, regarding the bitter pain management like that, but the catheter, as per the catheter is concerned, we have to put minimum 21 days because we just put the neo bladder and so that we keep the catheter for 21 days. As per your requirement, perhaps maybe the 5 days, but as per the surgical requirement, we kept this thing for 21 days.
That's good. Very good. So that was that.
Yes, sir.
And that means this is now the end for the surgery is over and the patient is.
That is already 1.5 years was that patient came few weeks back only, I think 10 days back, last OPD, and she is doing absolutely fine, sir, without any problem like that. And all the markers, chest X-ray and blood counts and USG abdomen pelvis was absolutely normal.
How long before you declare that the patient has no chance of recovery? How long do you wait? 5 years or what?
So that is the thing, sir. That is the literature, very scanty literature is there. But as per the literature, if the complete resection is there, the 5 years you have to wait like that. 5 years, the chance of recurrence is only 0 to 4%. So we have to see the for 5 years minimum like that to make this comment. Thank you, sir. Thank you very much.